Hello students, a very good evening. So we are back with our Farre series and the topic of today is genetics. So genetics per se is a very small topic and that's why we had just one single small lecture for it. What is important for your exam? Hi, good evening, facts. What is important for us for our prof exam is to remember the types of genetic disorders, pedigree analysis, because sometimes in your viva voce you can get a pedigree card and you have to interpret what type of genetic disorder it is, and also the examples of the common genetic disorders, right? And per se, when we talk about genetic disorders, Down syndrome is something which is very important because frequently a spotter or a short case or a clinical case can come in your exam. Also, a short note on Down syndrome, a short note on Turner syndrome. These are very favorite of university examiners, and not just the university examiners. When further you are going to give NEET PG or INICT, these genetic disorders are very important. So we are going to discuss one by one. Initially, we are going to make a solid base of types of genetic disorders. In types of genetic disorders, I won't go much into the detail. You already know genetics. You have been studying since class 8, but we are going to just revise down and write down what are the examples of the common genetic disorders, right? So without further ado, let's start. So firstly, what are the types of genetic disorders? So when we talk about types of genetic disorders, there are different categories. The first category that we are going to discuss is chromosomal disorders. So chromosome, you all understand, we all have 23 pairs of chromosomes. So if there is some problem in those chromosomes, either in the number of chromosome or in the structure of chromosomes, there's going to be some genetic disorder, right? So first category is chromosomal disorder. If there is a numerical problem, that means instead of 23 pairs of chromosome, we have some a different number. There could be extra chromosome, there could be less chromosomes. So that is a numerical problem. This is known as aneuploidy. Euploidy means 23 pairs of chromosome. If there is something different than that 23 pairs, that is known as aneuploidy. Second, we have structural chromosome problems. There could be deletion of some chromosomes. There could be duplication of some chromosome. There could be ulta, inversion of some chromosomes. Or there could be some translocation. That means some part of one chromosome has shifted to some other chromosome. So these are the structural problems. So this is all about chromosomal disorder. Now let's move to single gene disorders or Mendelian disorders. They follow the Mendelian pattern of genetics, right? As the name suggests, single gene disorders. So in these, there is one single gene mutation in a single gene is there, single gene mutation is there. In this we have different categories. If the problem in the gene is on the autosomal chromosome, so that would be autosomal dominant or autosomal recessive. It could be again X-linked recessive or X-linked dominant, or it could be Y-linked. So one by one we are going to understand what will happen in each of these and the classical examples that the examiners can throw at you. So firstly, we have autosomal dominant. So the name itself has dominant in it, right? So that means only one copy, one defective copy would be needed because it is a dominant disorder, right? And to remember the examples of these dominant disorder, I have a mnemonic for you. Many autosomal heroes never take our family's victory. So dominant people, remember, family victory. So many autosomal heroes never take our family's victory. And what are the mnemonic? This is the mnemonic. M stands for Marfan's, A is for achondroplasia, H is for Huntington's chorea, N is for neurofibromatosis, T is for tuberous sclerosis, O is for osteogenesis imperfecta, F for familial hypercholesteremia, and V for von Willebrand disease. So I hope this mnemonic helps you to remember these most commonly asked genetic disorders. So we are done with autosomal dominant pattern and we understand only one single gene would be needed over here. Right, now let's move to autosomal recessive. The name itself has recessive, so you need both affected allele. So both affected allele, if present, then only this disease would be there. And the mnemonic to remember this autosomal recessive disorders is CIST-PAL. CIST-PAL. C stands for cystic fibrosis, S is sickle cell anemia, T is for thalassemia, P for phenylketonuria, A is for albinism, and L is for lysosomal storage disorders. So done. Let's move to now the X and Y linked chromosomes disorder. Firstly, we have X-linked dominant. X-linked dominant. So whenever X-linked things come, think that whenever a combination is going to happen, father can either give X or Y. Mother can only and only give X. Right? Mother has both the X chromosomes, so mother can only give X. Father can either give X or can give Y. Right? Father is the one that determines whether the child is going to be a boy child or a girl child. Right? So in X-linked dominant, what will happen? X-linked dominant, that means one X chromosome, dominant X chromosome can be given further down. So if the father is affected, then obviously all the daughters will be affected. If mother is affected, what will happen? Then again, there is 50% chance that the offspring will be affected. But what about boys? If it is a boy child, then definitely father cannot give. So remember, in X-linked dominant, if father is affected, then the boy won't be affected. So no male to male. But if father is affected, all the daughters would be affected. So this is the core of X-linked dominant. Understood? So no male to male, an affected father if giving to all the daughters, that is X-linked dominant. And the examples for these X-linked dominant is females inherit rare victories. So X-linked dominant, X is for females and dominant means victory. So females inherit rare victories. The mnemonic is this: F stands for fragile X, I is for incognitia pigmenti, R is for red, and V is for vitamin D resistant rickets. Now let's move to X-linked recessive. Now in X-linked recessive, I need both affected X. Or if there is a male child, then definitely the male child has one single X. So if a carrier mother is there, that can pass down to all the sons. So no male to male again, but carrier mother can give it to sons. So for X-linked, the rule is no male to male transfer, because father is only going to give Y chromosome, not X chromosome to the male baby. So in both X-linked dominant and recessive, remember, no male to male transfer would be there. But in X-linked dominant, father is giving to all the daughters, and in X-linked recessive, carrier mother is going to give it to all the sons. The example over here is, oh, he didn't get her lovely face. Mother should only give her lovely face to the child, right? Not some defective gene. So the example, the mnemonic over here is, oh, he didn't get her lovely face. O is for OTC deficiency, H for hemophilia, D for Duchenne muscular dystrophy, G is for G6PD deficiency, L for Leishman, and F for Fabry's disease. And lastly, we have Y-linked inheritance, that is also known as Hollandric pattern. Here, because it is Y-linked and only males have Y chromosome, so only males are affected. And the examples over here include hairy pinna and infertility genes. So this was all about single gene disorders or Mendelian disorders. After that, the next category is multifactorial or polygenic disorders. The name itself has multifactorial. So different factors would be responsible for the inheritance over here. So different multiple genes along with the environmental influence would be responsible here for the expression of disease. The examples include neural tube defects, cleft lip, cleft palate, diabetes, and hypertension. So here, different factors along with the environmental influence would determine the expression of the disease. Then next we have mitochondrial disorder. Mitochondrial starts from M. Only mothers give mitochondria to us. The egg has that cytoplasm, and in that cytoplasm we have mitochondria. So whatever mitochondria we have is only and only from our mothers, not from fathers. So mother gives this disorder to all the offspring. Father, if affected, will never give to any offspring. So if in the pedigree you see that only mother is giving it to all the offspring and father is not giving it further, this is a mitochondrial disorder. And mitochondria, mothers, so the mnemonic here is mothers love my light. Mothers love my light. M is for MELAS, that is mitochondrial encephalopathy with lactic acidosis and stroke-like episode. LH for LHON, that is Leber's hereditary optic neuropathy. MRF, myoclonic epilepsy with ragged red fibers, and L is for Leigh syndrome. So these are the 4 major examples of mitochondrial disorders. Then comes the pattern that is going to be asked in your Viva exam. They can give you a pedigree and ask you to interpret about it. So firstly, let's start with the basics. We all understand if you have a square like this, that means a male child. A circle is for female. If I join these male and female by a single line, that means marriage. If double line, that means consanguineous marriage. That means marriage was between 2 relatives, 2 cousins. That could be first degree relative, second degree relative, third degree relative. Then whenever we are making a family, we make a flowchart beyond that. So each generation is depicted by Roman numerals. So first generation would be 1, further generation would be 2. This is represented in Roman numerals. And whenever we are writing down the siblings, then the oldest would be on the left. And as we go towards the right, that would be the last born. So first born would always be left, and then last born would be on the right. 1, 2, 3. So this is how we are going to depict a family. If there are twins, and these twins are identical twins, then we make a triangular bifurcation instead of that particular flow chart. Identical twins also have a connection in between them. If it is fraternal twins or non-identical twins, then we omit this connection. To show an affected male and female, we make them color by blocked black. And if there is a history of affected male and female, then we make these lines, stashed lines, shaded with that. A carrier is depicted by a dot in between. And if it is a deceased male and female, then we cross or strike out that. And unknown sex, we make a diamond. So these are the basics of pedigree that you should know. So now let's move on to the question that they're going to ask in the exam. Firstly, let's talk about the autosomal dominant pattern. What we understand about autosomal dominant pattern, that I need only one affected allele. So that means each and every generation would be affected. So vertically, if every generation is affected, this is a pedigree for autosomal dominant. And because it is autosomal dominant, there will be no sex predilection. Equal male and female would be there. And father to son transmission also will be there. So if in a pedigree you see that each and every generation is affected, and there is no particular affection towards male or female, and even father is giving it to the son, this is autosomal dominant pattern. Moving to autosomal recessive. For autosomal recessive, I need 2 affected alleles. So it is going to skip the generations. It is going to skip the generation, but amongst the siblings, most of them would be affected, right? So it will skip the generation, but amongst the siblings, there will be higher chances, right? So skip the generation, a horizontal spread, again equal male and female. And if consanguinity history is there, then strongly think about autosomal recessive pattern. Then we have X-linked. In X-linked, we discussed that no male to male is going to be there. If it is X-linked dominant, then affected fathers will give to only daughters. And if X-linked recessive, carrier mothers are going to give it to their sons. And finally, we have mitochondrial pattern of inheritance, in which only mother can give it to all the children. Father is not going to give to any the child. Right, so this is how you're going to read about pedigree analysis. So finally, let's give a quick recap so that in exams we don't make a silly mistake. So no male to male transmission in all the X-linked condition. No male to male in all the X-linked condition. All the X-linked condition, no male to male. If father is giving to all the daughters, this is nothing but X-linked dominant. If mother is giving to all the children, this is mitochondrial. And if you have a horizontal affection, consanguinity history, siblings are affected, this is nothing but autosomal recessive. So with this background, now you know about the types of genetic disorders and pedigree analysis. Now let's move down to genetic disorders per se. So the first genetic disorder that we are going to discuss is defect in the chromosome number, that is aneuploidy. And the most common aneuploidy that we have is Down syndrome. So remember, we all have 23 pairs of chromosome. Okay, so we all have 23 pairs of chromosome. If the chromosome number if the chromosome number is in the multiple of 23, then we label it as euploidy. But if it is not in the multiple of 23, we label it as aneuploidy. Right? Normally we have 23 pairs of chromosome. The most common chromosomal disorder that we have is Down syndrome. So remember, the most common chromosomal disorder is Down syndrome. And if we talk about the most common cause of congenital mental retardation, then that is also Down syndrome. The most common cause of congenital mental retardation is also Down syndrome. So now the examiner can ask you, can you tell me the second most common cause of congenital mental retardation? So remember, the second most common cause of congenital mental retardation is nothing but Fragile X syndrome, right? So remember, these are the one-liners that can be asked in the exam, during the viva, during your NEET PG. So these are the facts that are good to know. So what exactly happens in Down syndrome? In Down syndrome, we have one extra chromosome. What is that extra chromosome? We have one extra 21st chromosome. So it is trisomy 21. So why this child is having extra extra 21 chromosome? This extra chromosome could be due to variety of reasons. First, the most common reason, in 95% of the cases, this is going to happen. What is this? Maternal meiotic non-disjunction. What do I mean by that? What happens during the normal meiosis? The 2n will make n. So what happens initially? We all have 23 pairs of chromosomes. So the structure of the chromosomes would be like this, right? Two sister chromatids joined together. So imagine two twins that are friends. Now they have to split up. In meiosis 1, what happens? These individually will separate. That means one twin will go there, other twin will go there. What happens in meiosis 2? Now the sister chromatids need to separate, right? So that each of the gamete has n. This separation is known as disjunction. But if there is non-disjunction, that means they fail to separate, what will happen? This failure to separation can happen in meiosis 1 also, in meiosis 2 also. So first let's see in meiosis 1. If in meiosis 1 this happens, what will happen if they fail to separate during meiosis 1? If non-disjunction happens at the time of meiosis 1, then one cell is going to have again both the chromosomes, other is going to have none. So on fertilization, this section will have monosomy, one less chromosome, and other is going to have one extra chromosome, that is trisomy, right? So in cases if meiosis 1 is affected, all the four are going to be abnormal. On the other hand, if meiosis 2 is affected, what will happen? In meiosis 2, one side will get extra chromosome, other will get one less. So one will have n plus 1, here we have n minus 1. So this is the basis of extra 21st chromosome maternal meiotic non-disjunction. This non-disjunction is associated with advanced maternal age. As the mother ages, this chances of this non-disjunction, this non-separation increases. So remember, this maternal meiotic non-disjunction is associated with advanced maternal age. So I told you 95% of the cases this is going to happen. But there are certain other methods also in which we can have extra chromosomal material. What is that? Firstly, we have Robertsonian translocation. You know what are Robertsonian translocation? The chromosomes, acrocentric chromosomes that have a very short p-arm and a very long p-arm. If they undergo translocation, what will happen? If such two chromosomes undergo translocation, what will happen? One chromosome is going to have very little material, one chromosome is going to have very large material, right? So if Robertsonian translocation happens, there are chances that I can get extra material. So translocation between two acrocentric chromosomes. So translocation between 21-21 or translocation between 14-21. These are the causes of your Down syndrome, right? Remember, these other causes, these are not associated with advanced maternal age. So a young female can also have a Down syndrome child, because there are other methods also by which we can have extra chromosomal material. Third way is mosaics. What are mosaics? These mosaics are the individuals that have two or more than two cell lines within the same individuals. So two or more than two cell lines in same individual. Okay, then lastly we have partial trisomy, in which what happens, the 21st chromosome, it replicates. So the long arm of 21st chromosome triplicates, right? And remember what is important in all these three, these are not associated with advanced maternal age. Advanced maternal age, right? So now we know the pathophysiology behind it, the basics, why there is one extra 21st chromosome. Now let's move down to the clinical features of this Down syndrome. To remember the clinical features, I have made this line diagram for you all so that it is very easily to recall from head to toe what all features do you see in Down syndrome. So the most striking feature whenever you see a Down syndrome child is going to be hypotonia. What is hypotonia? The tone of the child would be very less. The child will be lying down listlessly, right? So the first is hypotonia. This is the most striking features. Now let's go from head to toe. Firstly, head. These children mostly have mental retardation. Down syndrome is the most common cause of congenital mental retardation. Now let's look at the eyes. Can you see how I've made the eyes? The outer canthi of the eyes are pointing upwards. So this pointing of upwards is known as a mongoloid slant. If it is pointing downwards, it is an anti-mongoloid slant. So pointing upwards, we have a mongoloid slant. Also, upper lid, they make a fold. This is known as an epicanthal fold. Epicanthal fold. Also, you can see certain spots in the iris. These are known as brush felt spots. In the iris, we see certain spots. These spots are known as brush felt spots. Now, after eyes comes the nose. How's the nose over here? Usually they have very flat faces. So flat nose, small nasal bone, flat faces. Right, then comes the tongue. Look at the tongue. I have shown the tongue over here. The tongue is protruding. So they have a protruding tongue. Open mouth and protruding tongue. We missed the ears. How are the ears over here? They are low set ears. Low set ears. Then let's come down to the hands. In the hands, you see a simian crease. What is a simian crease? You see a single transverse crease. A single transverse crease in the hands, that is simian crease. Also the fifth finger, the little finger, it is very long claw-like. This is known as fifth finger clinodictyly. Fifth finger clinodactyly. Right, now let's move to the heart. Heart, what are the congenital heart diseases that we see in Down syndrome? The most common congenital heart disease that you see in Down syndrome is endocardial cushion defects. Endocardial cushion defects. Now let's move to the gut. What do you all see in the gut? In the gut, intestinal atresia, annular pancreas, Hirschsprung disease. These are the most common associations with Down syndrome. So let's write down that together. We have intestinal atresia. So it can be a duodenal atresia, jejunal atresia. So intestinal atresias, annular pancreas, and we have Hirschsprung disease. Lastly, we have foot. In foot, you see what is known as sandal gap. Sandal gap. So remember the kanchi chappal you wear, kanchi chappal, in which the division is between the great toe, thumb, and the remaining toes. So here also, if you look at the feet of the child, you see a unusual gap in between the great toe and the other toes. So this is known as sandal gap that you see in Down syndrome patients. So this is a line diagram for you to remember in the exam, head to toe what all things you are going to see. Apart from that, other features, these children, Down syndrome children, are, because of that extra chromosome, they are at risk of certain diseases, right? They have increased risk of hypothyroidism, increased risk of atlantoaxial dislocation. That's why after the age of 4, we advise X-ray neck to all of these children because they have higher chances of this dislocation. Also, they are all at the higher chances of developing leukemias, blood cancer. And if you look at Down syndrome patients, the most common type of leukemia that they encounter is ALL, that is acute lymphoblastic leukemia. But AML, most common is M7 type, that is the megakaryocytic type, right? And in smaller children, that is age less than 3 years, again the most common leukemia that they encounter is this AML. Also, they have higher chances of conductive hearing loss, and if you have read about Alzheimer's disease, what happens in Alzheimer's disease? There is accumulation of APP, and that is coded by the 21st chromosome. So these children, they have extra 21st chromosome. That means the accumulation of APP would be quite sooner. So they have pre-senile Alzheimer's disease because of the extra 21st chromosome. So higher chances of pre-senile Alzheimer's disease. Because on 21st chromosome you have this APP. And low IQ, developmental delay, that is universal in this Down syndrome patient. Once you have a Down syndrome patient, you cannot expect that patient to be having a normal IQ or be useful for the society. So remember this low IQ and developmental delay, this is universal. So we definitely don't want a child, a Down syndrome child, to be here with us because that won't be very useful for the society. That's why antenatally we screen for Down syndrome, and if there is a Down syndrome patient, a Down syndrome child, then the parents can decide whether they want that child to be born or aborted. So for that we have antenatal screening. Before moving to the antenatal screening, let's look down into pictures. I've made a line diagram, but that line diagram definitely won't come in your exam. They will give these pictures only. So look at this child. Can you see flat faces? A flat face is very small nasal bone, a mongoloid slant, open mouth and protruding tongue. And look at the neck. There is increase in the nuchal thickness. This is a single transverse crease, that is simian crease. So let's now move to the antenatal screening. What do we check in antenatal screening? We have certain markers in the first trimester, certain markers in the second trimester, right? So in the first trimester, the easiest one to pick is ultrasound. What do we check in ultrasound? We look at the back of the neck, that is the nuchal thickness or nuchal translucency. If the nuchal thickness, can you look over here? We are checking the back of the neck of this child. So if the nuchal thickness, a translucency, is more than or equal to 3 mm, that is considered to be suggestive of Down syndrome. So to confirm, we go for certain markers or test. In first trimester, we do something that is known as double test. In double test, you check two things. We check PAP A and beta HCG, TAP A and beta HCG. And in second trimester, we have triple test and quadruple test. In triple test, we have beta HCG, unconjugated estriol, and alpha fetoprotein. And in quadruple test, all of these triple markers along with inhibin, we go for. Now, what they ask in the exam, which of these increases, which of these decreases? So, very easy to remember. Remember HCG, H for high, inhibin, I for increase. So, these HCG and inhibin increase, rest all decrease. So, very easy to remember. Right, so just remember the components and it would be very easy to remember which all increase and which all decrease in Down syndrome. Right, confirmatory, we usually go for a screening test, NIPT, that is a non-invasive prenatal testing, in which what do? We just take the blood sample of the mother, and blood sample of the mother would have certain cell-free DNA of the baby, and by picking up that DNA, we can pick up the chromosomal problems, right? So in this, we use cell-free DNA from the mother. So it is very non-invasive. You don't have to poke the baby to take the DNA sample. We're just poking the mother and taking the cell-free DNA out of it. But definitely the confirmatory test would be karyotyping. We take the genetic material from the baby either by amniocentesis or chorionic villus sampling. By those methods, we extract the DNA and go for karyotyping. And if karyotyping you see one extra 21st chromosome, that's a Down syndrome child. So this is all about Down syndromes. Now let's move down to the next syndrome, that is the Edward syndrome. So the first most common trisomy we discussed, that was Downs. It is the second most common trisomy. And can you tell me what trisomy is Edward syndrome? E for Edward, E for 18. E for Edward, E for 18. So this is trisomy 18. What do we see over here? Look at this child. Look at the occiput. How is the occiput looking? It is elongated, very prominent. Look at the fingers. Overlapping fingers are there. Look at the ears, very malformed dysplastic ears. If you look at the feet of the child, how is the feet? Look at the bottom of the feet. It looks like a rocker bottom feet. This is the rocking chair. Look at the bottom of the rocking chair. The feet looks like that only. That's why these are known as rocker bottom feet. Rocker bottom feet. Right, rocker bottom feet. So this is all that you see in Edward syndrome. You see an occiput that is elongated and prominent. The digits are overlapping. Feet are rocker bottom feet. They have predisposition to certain congenital heart diseases, the most common being ventricular septal defects. Kidneys, they have renal anomalies like horseshoe kidneys. And again, these children have intellectual disability. The most common cause of death in these patients is nothing but apnea, that is cessation of breathing, respiratory failure. So the most common cause of death here is apnea or respiratory failure. So this was all about trisomy 18, Edward syndrome. Karyotyping first trimester में भी कर सकते हैं, कभी भी कर सकते हैं, but we firstly start with some screening test, and if evidence is there of positivity is there of the screening test, then we go for confirmatory test. Karyotyping can be done anytime, right? So let's move to third, Patau syndrome. Okay, Ayush. Now let's move to the next trisomy, that is Patau. Edward was 18. This is 13. Trisomy 13. What do we see over here? Look at this child. Again, we have dysplastic ears. We have overlapping fingers. But what is prominent over here? The midline issues. Can you see cleft lip, cleft palate? Also in brain, they have holoprosencephaly. So midline issues are there. So wherever you see a midline issue with this elongated head, overlapping fingers, dysplastic ears, don't go for Edward. This is Patau. So whenever you see midline problems, this is Patau. Rocker bottom feet can be seen in both, but more prominent in Edward syndrome, right? So this is for your to remember in the exam. If they say rocker bottom feet, then it can be seen in both Edward as well as Patau. But if you have to choose one, choose Edward. And if they go for midline problems like cleft lip, cleft palate, then go for Patau. Right, so this is the major difference. This is trisomy 18. Rest all very similar features. They have small head, that is microcephaly, holoprosencephaly. They have cleft lip, cleft palate. Digits are again overlapping. I told you midline problems in the brain, that is holoprosencephaly. Like the Edward syndrome, they also have congenital heart defects like ventricular septal defect. They have renal anomalies, and feet, they can have rocker bottom feet. Right, so these are the two important disorders or trisomies after Down syndrome, Edwards and Patau. The screening test done for Edward and rest of these are very much discussed in your OBGYN lectures. For here, we just need to pick up the features, because for pediatrics, they are going to ask about these in the viva pointers and going to give the images, not a thorough investigation pattern for Edward and Patau. For Downs, they can definitely ask, but for pediatrics per se, these two disorders, you just need to know the clinical manifestations, nothing else. Screening test, definitely we go for different markers, and they can be either increased or decreased. We have a table that is discussed well versed in your OBGYN lectures, right? So we are not going into that detail. Now let's move to the another chromosomal problem. We are till now we discussed trisomies, that is extra chromosome. Now let's talk about monosomies, that is one less chromosome. And the most common of these monosomies is Turner syndrome, that is monosomy X. Monosomy X. So this child has XO, one less chromosome. So because they don't have Y chromosome, these are only going to be females. This is a chromosome number problem, right? This is a chromosome number problem or disorder. Right? On the other hand, what the students confuse, Noonan syndrome. They say Noonan syndrome is male Turners. So remember, this Noonan syndrome is not male Turners. What is Noonan? In Noonan, there is a gene mutation. There is a gene mutation. Which gene mutation? PTPN11 gene. PTPN11 gene mutation. This gene is on chromosome number 12. Right? So this is a single gene disorder, not a chromosome number disorder. So it is definitely not a male Turner's. Though the facial features are very similar of Noonan's and Turner's, but remember, Noonan is not male Turner's. So when we talk about Turner and Noonan, in Turner the karyotype is XO because the Y is not there. These are only going to be females. But on the other hand, Noonan's is a gene problem, not chromosome number problem. So here the karyotype can be either 46XX or 46XY. Right? So these can be both male or female. So allocating a sex to Noonan that it is male Turner is wrong. It can be either a male, it can be either a female. If you talk about IQ, the Turner syndrome patients, they have a normal IQ. But Noonan's, they have low IQ. If you talk about the fertility, then these females, Turner females, they have streak ovaries, non-functional ovaries. So they are going to have amenorrhea, infertility. So these Turner syndrome have normal intelligence, but they cannot produce babies. Normal intelligence, but cannot produce babies. On the other hand, these Noonan patients, though they have low IQ, but the females here are fertile. They can produce babies. Females are fertile. And what about males? Males, they just have undescended testes. Undescended testes. So they can also be fertile. Right? So I remember it that way, that Turner female, though they have intelligence, they have brains, but they cannot have children. On the other hand, Noonans, they have low IQ, but they can produce children. Now let's move down to the anomalies. Again, we see renal anomalies, we see your cardiovascular anomalies. Renal anomalies in Turner syndrome, we see your horseshoe kidney. And for cardiovascular, remember which side of the brain is more analytical? It is the left side of the brain. These Turner syndromes are intelligent, so they are going to have left-sided heart problems. This is how I correlate. There is no logic behind it, but it helps me to remember that Turner syndromes, because they are intelligent, they are going to have left-sided heart problems. So left-sided heart issues. What is on the left side of my heart? We have left atrium, left ventricle, we have aorta. So they have aortic problems. What are these? They have coarctation of aorta, they have bicuspid aortic valve. On the other hand, they are also again going to have renal issues. And what about heart issues? They have low IQ. The right-sided heart problems would be there. What is there on my right side? Right atrium, right ventricle, pulmonary veins, right? Pulmonary arteries. So they will have pulmonary artery problem. They have pulmonary stenosis, right? So this is the differentiate between Sutapa, Samantha, males have undescended testes. Okay. So this is about two important genetic syndromes, Turner and Noonan. Noonan and Turner, I discussed it side by side because children confuse these Turner and Noonan to be sisters, Noonan as male Turners, but remember Noonan is not male Turner. So this is the overall habitus. What is the habitus? Usually they have a short stature, low hairline, droopy eyelids, widely spaced nipples, heart defects, congenital heart defects. They have streak ovaries, so amenorrhea, pubertal failure, infertility, increased carrying angle. And this Noonan's males, they have high anterior hairline, triangular shaped face. So these are the features of Turner and Noonan syndrome. Now after that, let's move to small disorders. Firstly, we have microdeletion syndromes. The name itself has microdeletion. That means a very small deletion is there. Very few base pairs are deleted. So definitely I won't see such base pair deletion on karyotyping. On karyotyping, we just see chromosomes here and there. So if there is entire chromosome deletion, I can pick up. But the small base pair deletions, I cannot pick up. So remember, these are not detected by karyotyping. For that, we need FISH, CGH, MLPA. Captain Jack Sparrow, you can drop your doubt in the comment section. I will read it and answer if it is worth. Now let's talk about these microdeletion syndromes. In this, I want to discuss two syndromes, DiGeorge and William. In DiGeorge, what do we all see? We see catch-22. This is the mnemonic catch-22. What is C? What is C? Can anyone tell me what is C? C stands for cardiac problems. A is abnormal facies. C is for your thymic aplasia, right? C is for, can anyone tell me catch-22? Are you all here with me? Is there a lag? Okay, there's no lag. So C again, catch-22, C is cardiac problems, abnormal faces, thymic aplasia. C is for cleft lip, cleft palate. H is hypocalcemia. And 22 is the 22nd chromosome. Right? So this is about DiGeorge syndrome. Now let's move to Williams syndrome. In Williams syndrome, again, it is a microdeletion chromosome. The deletion is on chromosome number 7. Long arm of chromosome 7. Here, what do you see? You see this such type of faces. Can you look at this child? Triangular faces, high arched cheekbones, a very smiling face, right? Looks like an elf. Elf on elf, the helpers on Christmas, elf. So these are the elfin faces. You see an elfin faces over here. These children, look at how smiley, friendly personality is there. So they usually have a friendly personality. They have a very laughing face, smiling face. But sadly, their IQ is low. They have a low IQ. And they have predisposition to certain cardiovascular disorders like supravalvular aortic stenosis, supravalvular aortic stenosis. And in DiGeorge, you saw hypocalcemia. Here we see hypercalcemia. So this is about Williams syndrome. So two microdeletion syndromes we discussed. Now let's move to genomic imprinting disorders, in which we are going to discuss about Angelman syndrome and Prader-Willi syndrome. So firstly, what is this genomic imprinting? Look at me. My hair are just like my father, but my eyes are just like my mother. So each of us have got two alleles, one maternal allele, one paternal allele, but we finally express one. We express one, right? We cannot be both like our mother and father. We have certain features that resemble our mother, certain features that resemble our father. So normally we have one maternal allele and one paternal allele, but one is expressed. So either maternal will be expressed or either paternal would be expressed, other will be silenced or deleted, right? So normally one allele is expressed, one allele is known as the active allele. One allele is active, one is the active allele, and other is silenced or deleted, or this is also known as the imprinted allele. Right? One is active and the other is silenced or imprinted. What will happen in this imprinting disorder? In this imprinting disorder, the active allele, the allele that should have been active, is actually deleted. So there is deletion of the active allele, deletion of the active allele. Or what happens? The inactive one is doubled. So there is disomy of the imprinted or inactive or silenced allele. So this is what happens in imprinting disorder. Normally the one that should have been expressed, the one that should have been active is deleted, or the one that should have been silenced is disomed. Mostly this deletion follows. So remember, in 70% of the cases this is going to be there. So remember this. The other one you can reduce by making it vice versa. So two important disorders we have Prader-Willi and Angelman. P for Prader-Willi, P for Papa, P for paternal. So what happens over here? The deletion you have to remember. So which gene, which allele is deleted? P for Papa, P for paternal, father's allele is deleted. So there is deletion of paternal chromosome 15q, long arm of chromosome 15q. This happens in 70% of the cases. In rest 30%, what will happen? Ulta. Disomy of maternal, Similarly, for Angelman, mothers are angels, so deletion of maternal 15q. And disomy of ulta ho jayega, paternal 15q. Now let's look at the features. To remember the features, I have these mnemonic. Prader-Willi bacha is a fat, stupid bacha, is a fat, stupid child. On the other hand, Angelmans are happy puppet. So look at this child, fat and stupid, fat and stupid. These children have, because of the fat, very small eyes, small digits, they are fat because they're eating more. They have hyperphagia, obesity, hypogonadism, low IQ because stupid. So fat, stupid babies. Right? What about Angelman? Look at this child. This is an Angelman bacha. Very smiley. Inappropriate laughter is there, and you all know, if you are laughing inappropriately, you definitely have a very low IQ. So inappropriate laughter is there, very low IQ is there. I told you, happy puppet, happiness, we got it. What do I mean by puppet? Have you seen puppet, how they dance? ataxic. They are ataxic, so they have ataxia, seizures, and hypotonia. Because of the hypotonia, they also have feeding difficulties. So this is Prader-Willi versus Angelman. Fat stupid baby is a Prader-Willi baby, and happy puppet baby is an Angelman baby, right? Okay. So just to complete, I have two or three genetic disorders left. First is Treacher Collins. Treacher Collins. Right? These are not very important for your exam, just good to know once. Treacher Collins, Pierre sequence, because further in your NEET PG or INI exam they can be asked. And then we have fetal alcohol syndrome, fetal Hydantoin syndrome. So just let's go through them very quickly. We have Treacher Collins syndrome, also known as the mandibulofacial syndrome. Mandibulofacial syndrome. Why this is known as mandibulofacial syndrome? The name itself has mandibulo, that means some problems with the mandible, and facial. So that means there is some facial problem, facial problem. So what happens in this Treacher Collins syndrome? What happens in this Treacher Collins syndrome? We have certain facial features. Remember in Down syndrome we discussed mongoloid slant, where the outer canthi of the eye was up, pointing up. This was the mongoloid slant. What is anti-mongoloid? When it is pointing downwards. So can you see over here? The outer canthi is pointing downwards, so they have anti-mongoloid slant. In eyes, they have coloboma. The eyes also look very sunken to me. They have sunken eyes. Hair distribution is also very atypical. They have teeth problems, jaw problems, mandible problem. There is an underdeveloped mandible. Also, cleft palate is there. So, here what happens? This syndrome has an autosomal dominant inheritance, and the gene that is affected is TCOF1 gene, that is on chromosome number 5. We have anti-mongoloid slant, coloboma, sunken eyes, teeth abnormalities, underdeveloped mandible. Then second is this Pierre-Robin sequence. What do you see in Pierre-Robin? Robbins, you remember Robbins? Robbins was a very favorite book of us in second year, right? Each and every one of us has brought that Robbins and read it very thoroughly, right? Very easy book, very interesting book. So most of us enthusiastically join MBBS at 17, at the age of 17, right? And you're going to, if you're a girl, you are going to read this Robin in your girls' common room. So the mnemonic to remember this Pierre Robin sequence is girls' common room. Girls' common room at the age of 17. Remember, this Pierre-Robin sequence is not a genetic disorder per se. It is associated with different genetic syndromes. So Pierre-Robin sequence can also be seen in fetal alcohol syndrome. It can be seen with Stickler syndrome. So different genetic syndromes can have this sequence. This is not a genetic disorder per se. This is the constellation of features, a sequence that we can appreciate. So girls common room 17. G is for glossoptosis. C is for cleft lip, cleft palate. R is for retrognathia, that is retracted jaw. And 17 is to tell you that chromosome 17 issues, SOX mutations, SOX 9 mutations can also lead to this Pierre-Robin sequence. Apart from that, associations I told you, they are associated with fetal alcohol syndrome, Stickler syndrome, right? So this is all about your Pierre-Robin sequence. Okay, so lastly, wrapping up the session with the fetal alcohol syndrome and fetal Hydantoin syndrome. Just small topic, fetal alcohol syndrome. When this fetal alcohol syndrome will happen, if a pregnant woman is taking alcohol, then this child can develop fetal alcohol syndrome. So to remember the features of fetal alcohol syndrome, remember if you have been drunk or if you have seen a drunken person the day after a heavy night party. So the eyes would be very sunken because of the dehydrations. So here the eyes look small. The philtrum is very smooth. Upper lip is very thin. And remember, these heavy night parties are usually after a breakup. So they are going to have congenital heart diseases. They have septal defects. So these are the features of fetal alcohol syndrome. You see that the eyes are small, the philtrum is smooth, the upper lip is very thin, and they are predisposed to septal defects and congenital heart diseases. Now let's look at the second part, fetal Hydantoin syndrome. Here, the pregnant female is taking hydantoin, phenytoin. So if the mother has epilepsy and is taking phenytoin for that same, and mother goes to a PHC, and the PHC doctor over there is not probing much into the history, and mother continues to take phenytoin throughout. Phenytoin is teratogenic. It can lead to fetal Hydantoin syndrome. So to remember, the mnemonic over here is PHC. Right, the story is just to remember the mnemonic, that fetal Hydantoin, because mother went to a PHC and did not give a thorough history. So PHC, P is for phalanges. The phalanges, they have hypoplastic phalanges. Hypoplastic phalanges. H is for the head. They have a small head, that is microcephaly. And P is for again cleft lip, cleft palate. Okay, so this is all about the important genetic syndromes that is important for your exam point of view. McCune-Albright syndrome would be discussed with the neuro section, not over here, right? So these are the core genetics. We firstly discussed about the types of genetic disorders, then individual genetic disorders, in which we discussed about Down syndrome, trisomies like Edward, Patau, microdeletion syndromes like DiGeorge syndrome, your Williams syndrome, differences between Turner and Noonan. We discussed about imprinting disorder, how imprinting disorders happen, and Prader-Willi Angelman. And lastly, we discussed about these Treacher Collins, Pierre Robbins, fetal Hydantoin syndrome, and fetal alcohol syndrome. If you have any doubt regarding any of these topics, please drop that down in the comment section. I'll be more than happy to help you over there. Otherwise, you can wrap up the session. Have a nice day, nice evening, have good food. Happy Sunday. So any doubt over here? Yes, this series is going to be definitely continuing with all the 19 subjects. This is the fourth prof going on right now. So how to enroll? You have to download the MedEd app and explore the Farre series. We are also here on the YouTube to get the PDF notes. We have a link over here in the comment section from the official PW MedEd channel. You can check out the annotated PDF notes as soon as this session ends. Okay, so thank you. Have a nice day, nice evening.